What is a penile implant?
To be very scientific, it is an implant that goes in your penis.
Done. Episode over. Thank you very much. What is up, guys? Dr. Alex Tatem here, a men's health expert, and today we are going to be talking about erectile dysfunction and penile implants. So, Kristen, tell me, what is a penile implant?
To be very scientific, it is an implant that goes in your penis.
Done. Episode over. Thank you very much.
So, if we kind of like take it back to the beginning again, what are your erections? Baseline, they're just two inflatable tubes that start deep in your pelvis and come out the shaft of your penis. And so what's supposed to happen with stimulation or arousal, you get a rush of blood flow in.
Or a very awkward math class in 7th grade. It
pinches off the veins to keep an erection. After orgasm, then those valves open back up. Blood flows out and you go flaccid again. But I usually just tell guys, that system can go wrong in multiple different ways.
Yeah.
Age, number one, like guaranteed factor to have you have changes in the erections. And there's treatment options for erectile dysfunction. Mainly you look at oral medications, injectable medications, vacuum erection devices, and you have the implant. And so just across the board, there's different treatment options, and the implant is one of those options. Whenever you're comparing it to the others, it's more of like a long-term functional fix. I usually tell guys too, and I think we both kind of compare it to like a knee replacement or something, saying, that's a functional fix for a joint that's not working the way that it used to. And then in our situation, you have these two inflatable tubes that go into the penis, and they're a replacement for those tubes that aren't working the way that they used to.
Yeah. I think it's important to kind of go back to what we talked about earlier about how the male sexual experience is, 4 separate things: sensation, erection, orgasm, and ejaculation. And whenever we're talking about a penile implant, we're talking about just fixing the erection. We are not talking about altering sensation, orgasm, or ejaculation. An implant just lets you become rigid again and let you have penetrative sex. It doesn't change anything when it comes to sensation, orgasm, or ejaculation, which I think is a common misconception.
There's so many misconceptions about the implant in general, I think. Yeah. And the other big one is that it's not an enhancement procedure, right? Yeah. So it's not like a penis replacement surgery or
there is no
like
replacement
that.
For a penis.
Yeah, exactly.
It is its own thing.
Reasonable expectations, always very important.
Yeah. Something that I think is really common is that there's a lot of misconceptions surrounding penile implants and a lot of hesitancy and fear whenever men are starting to, go down their erectile dysfunction journey. I don't think anybody has the same level of fear, at least not as a society, when it comes to things like hips or knees. But in the world of penile implants, like it's almost really taboo. Why do you think that is?
Probably just because people talk about like your joints more. I don't know, like you don't care to talk about it to anybody off the street, even to say like, oh, I had my hip replaced, I had my knee replaced, or something like that. But so people just don't talk about it as much, probably. But then also, it's scary, I'm sure, to think about having surgery on your penis. Yeah. And whenever you don't know everything that goes into it, it's intimidating.
Yeah. Well, I think that's probably some really good points there. Another thing that I've commonly seen is, patients who have, a misunderstanding of what the implant is. They think there's going to be something external or foreign, or someone's going to be able to look at them and tell. I mean, with the majority of our patients, I don't think you can tell, looking even as close as we are right now.
No, what I tell patients a lot too is how many times have you heard a story about say a patient in the hospital who has an implant, but the nurses don't know that he has an implant. Yeah. And so, whether it's they think they have an erection or something, or even, if you hear stories about the emergency room and somebody having an implant, but they think that they have a priapism, and so they stick needles in it or something, So no, that I usually say it. Sometimes there's even medical professionals who aren't sure that you have an implant. So
yeah, it's true. I think most medical professionals outside of urology probably don't know anything more about implants than patients, watching any video online.
Yeah. I mean, definitely just looking at somebody naked with an implant No.
You'd have no
can't tell.
idea.
No.
Yeah.
No.
Yeah.
And then I think fear from, again, since it's not talked about so much, like, I think people think this is a new thing that's like new to the market, you know, fresh off the press. But like, what's the history on the implants? Go through that a little bit too.
Sure. Yeah. So implants were actually designed by two, main, physicians at separate times. So I believe it was in 1972 to 1973. There was Brantley F. Scott down in Houston, Texas, who developed the first inflatable penile implant, which he was always a tinkerer, kind of an inventor, type individual. And he had come up with this device in collaboration with a biomedical engineer that he was talking to over the phone. And in order to test it out the first time, he actually broke into the morgue in Houston. Yeah, broke into the city morgue. And,
the 70s.
and then implanted this in a cadaver, a dead person, and then called from the phone either inside the morgue or the payphone that was right outside, calling the engineer, letting him know that it worked. Okay.
Wild.
And so that was the start of the inflatable. And then at the same time, down, I believe in Miami, Dr. Hernan Carrion developed what was known as the Carrion small prosthesis, which is terrible naming convention. Small was actually the doctor that he was working with at the time. But then Dr. Carrion came up with the semi-rigid or the malleable prosthesis, which, believe it or not, was actually put in with a incision actually behind the scrotum, a perineal incision. So something that was wildly different than what we see and do today. But they first started back in the early 70s and have been improved every single year since then. And when you think about it, have been around for probably 20 years more than breast implants. First breast implants weren't until I think the late 80s, maybe.
I do not know.
I know, right?
I didn't brush up on my breast implant history.
We operate next to plastic surgeons all the time, but we never talk about the history of it. But no, so, the penile implant has been around for over 50 years at this point.
Yeah. So, and it's been around longer than PDE5s. So
yes.
Like your Cialis and Viagra and everything, so it's so interesting.
Yeah. And the reliability data on penile implants is actually the best out of any implanted medical device, if you're looking historically. So it's better than any hip or any knee when it comes to revision rates and longevity, which is pretty darn impressive.
Yeah. So you mentioned two different types of implants, malleables and inflatables. So what's the difference? Why are there two?
Sure. So the difference is basically how the devices work within the corpora, within the erectile bodies of the penis. So the malleable is probably the easiest to understand. In the surgical world, we'll commonly refer to them as rods. These are flexible, bendable rods that are slid inside the erectile bodies and can then kind of hold their shape whenever they are manipulated up, down, left, right. And patients can, direct them up for intercourse and then push them down whenever they're, wanting to put on their pants and go about their day. The problem is that you're never fully rigid and you're also never fully flaccid. And so although the device is very technically simple, they almost never break. The drawback is it's not as satisfying or as natural as the second option, which is the inflatable implant. And the inflatable implant historically has been a little bit more complex device, but it is hydraulic, which is actually kind of nice because the penis is naturally a hydraulic organ. And the inflatable implant consists of three pieces. So there are the inflatable tubes that go inside the corpora. There is the pump, which goes at the bottom of the scrotum. And then there is a reservoir or a tank of fluid that sits inside the abdomen, whether in a fat pad or between the muscle layers of the belly, where it's hidden away and holds the saline when it's not being used for an erection. And so that allows the penis to be fully flaccid whenever at rest, and then fully erect and fully rigid when engaging in sex.
Yeah, the malleable implants, it's funny. A lot of times I'll describe them to patients as Gumby.
Yeah.
And then I like when people know what Gumby is.
Yeah.
Some people don't. And then for the inflatable, so you said it's saline. I have a lot of patients ask, what is that fluid? So it's saline and it's put in at the time of the procedure. And then it's just transfer of fluid back and forth. And it's not, so we don't have to like refill this. I have patients ask that too, like how often do you have to refill it or something?
I often wonder if we had to refill penile implants, how long the line outside our clinic would be on Friday afternoons. Like, I think we've got to the point
I'm
where,
just happy we don't have to do that.
yeah. We'd probably reach, all the way outside the city limits at this point. So, like we know that penile implants are very safe and very effective, but, could you kind of walk through like what the process looks like for men that are being evaluated for an implant and what that looks like leading up to the day of surgery?
Yeah. So, I mean, it can start in all different ways. Maybe we're seeing them as a new patient, or maybe we've been following them. And it's, whenever you talk about treatment for erections, I always tell guys, you want to start with pills, and, they're the least invasive. And so start there. If they work, great. If they don't, then we have these other options.
Yeah.
But it's also not like you have to keep climbing that ladder forever and ever. And the implant doesn't have to be seen as like the last possible option, or last ditch effort or anything.
Yeah.
So I tell guys, like, once you've tried and failed pills, it kind of opens up the door for you to try anything else.
The term that I hate that I've heard some doctors use when talking about the implant, like, oh, it's an option of last resort.
Oh,
yeah. I'm like, well, yeah, it's a last resort in the way that like a hip replacement is a last resort, because once you have a hip replacement, like you don't need any more ibuprofen, right?
Mm-hmm.
Like you don't need any more steroid shots. Whenever a guy has an implant, the comment that people make is like, oh, you can't go backwards. And it's like, dude, forget going backwards. Like right now, like you're in a terrible spot.
Yeah. What
like,
are you going backwards to?
Exactly. Like nobody gets an implant because they have a perfectly working penis. They they get an implant because they have terrible erectile dysfunction. They want to get their sex life back.
Yeah.
And so, whenever patients ask like, oh, is the implant good? And, is it feel natural? I tell patients that the majority of partners don't even know that you have an implant if you don't tell them. Like, I tell guys
That might be an exaggeration.
Honestly, I have had so many men tell me that their partners have no idea. Now, this is the patient telling me, right? So maybe they're a little suspicious. Maybe around like the hour and a half mark, they're like, something's a little funny here. This is not tracking. But I remember, teaching patients, you can just go into the bathroom, inflate the device, you get a firm, rigid erection, and then, you just come out for your debut into the bedroom. And, I really don't think it is as noticeable as, what many people are afraid of.
Yeah. No, I just think it's a balance there of like what you tell patients for, because same thing. I have a lot of guys ask me that question, or like, does it feel, am I going to notice it? And that kind of stuff. Or like, and I'm like, well, it is something that is new in your body that hasn't been there for your entire life up until now.
Yep.
And so like, you're going to notice it at first, and you're going to feel it. And, with having the cylinders in the penis, it can also mean that like you don't retract as much as you used to, right?
Yeah.
And so there's changes that happen.
You go from being a grower to a shower.
Yes. And but whenever you're saying like, I think it's still natural feeling, whenever you don't have an erection, and then definitely whenever you have an erection and everything too. But it's just not to gloss over, like it is something different.
Yeah. It's going to be different. But if you're a man with erectile dysfunction, different could be a good thing.
Sure.
Yeah. So, patients, let's say there's a guy who has been struggling with erectile dysfunction for a couple of years. The pills have stopped working, right? Maybe he's tried injections, maybe he hasn't, he's kind of afraid of them. Like, how do you counsel that patient when he comes to your clinic?
Yeah. So I kind of review those options again, whether he's tried injections or not, because there's a lot of layers to like injection dosing and everything. But again, if you tell me I never want to stick a needle in my penis, that's fine.
Yep.
I'm not here to make you do that or anything. And so then whenever I talk about the implant, I just kind of go back through that history, what erections are, how they work, and then what the implant is just trying to do, again, is giving you a rigid penis that you can use for penetrative sex. And I talk about kind of the whole process that, we check insurance coverage, which, the majority of guys who get an implant, it's because it's covered by insurance. Most guys aren't out here paying cash or anything.
Yeah.
And which a lot of times they're surprised by that too, because when you're talking about insurance coverage, it's not great for other treatment options.
Yeah.
Pills or injections or anything.
Injections
like that.
are never covered by insurance. Yeah.
And so then, that can be a real positive with the implant. So we always check that first. And then I tell them, it's a 30-minute outpatient procedure. So you're not staying in the hospital overnight. You're going home to your own bed. For us in the OR, it takes about 30 minutes. For them, it's like a half a day experience. Yeah, whatever. It's so, and for
I'm
them,
very proud of my surgical times. Kristen's always trying to say I'm slower than I actually am. It's fine.
It is fine.
Yeah.
And so, and usually we're doing these at a surgery center too. It's where we do a lot of them. So like our teams in the surgery center, they're very efficient and everything. So whenever they wake up from surgery, they kind of have a big fluffy dressing over everything. We do an incision down on the scrotum. We'll kind of talk about different approaches for that too, but we're generally doing what's called a peniscrotal incision.
Yep.
And so everything is done through one incision, and then we just use dissolvable stitches and dissolvable glue. So nothing that you have to worry about for local wound care. What are you questioning?
Well, I'm trying to think of when is the last time that I've ever needed to make a counter incision for a reservoir.
Since I've been here.
Yeah. This is something that we debate surgically all the time, the need for a counter incision. And again, that's more of like a surgical discussion than a patient discussion. But I think that it's kind of reassuring for patients that, you know what you're going to get, right? Like at least in our practice, like, if we think we can do this through one incision, we probably can. The only time we're making a second incision if somebody has terrible Peyronie's disease or something like that.
Yeah, but no, in 2.5 years of me being here, we've never made a counter incision for it. So, one incision, and so then we slide an inflatable tube on either side of the penis, pump down in the scrotum, a reservoir that kind of sits up in the belly in between some muscle layers, and then I say we do a temporary drain that comes out of the skin. We take that out 2 to 3 days post-op, and then take the dressing off at that time. Once the dressing is off and the drain is out, nothing else on the outside at that point in time. And then we usually see them back 3 weeks later to start teaching them how to cycle the device, inflating and deflating, and having them start using it and everything.
That's another thing I hear from patients, because I think there's a lot of resources online that tell patients they have to wait 6 weeks before using the device. And sometimes we do have patients wait that long if we're doing more advanced work or it's a revision case or something like that. But for our patients that are, getting a first-time penile implant, I mean, we've got them using their device in 3 weeks, and they most of them, tend to do really well.
Oh yeah, I think post-op course is generally good. And it's so funny though. I mean, it's such a spectrum that I've seen some guys in who are like, I'm feeling great. I didn't use any medications post-op or anything. And then other guys who are on the opposite end, So it's really, really hard to generalize it, obviously. But for the most part, and we do non-narcotic post-op pain medications. And I would say that large majority do really, really well with that.
Yeah.
And then, start having them use it at 3 weeks. And then it's also like, I mean, at 3 weeks, are you going to be 100%? Nope. Don't expect that. And that's okay. But you can start into it, and then I usually see guys back then 3 months post-op. And I just saw a guy either this week or last week. And he was like, you need to put in your post-op information that it's going to be a couple months before like you're doing amazing. And I was like, if we put every tidbit in our post-op instructions, it would be 100 pages. But
and it's already how many pages at this point?
Long. I don't know.
It's too long as is. Yeah.
And so, it just takes some time. But the more time and effort that you put into it, like the better outcome you're going to get too. Yep. And then we also kind of equate it to joint replacement, saying it's like going through physical therapy or something, that you're doing these regular exercises, you're using it. But long-term maintenance isn't really anything other than using it. So.
Yeah. I think a couple pumps, maybe once a day, just to try and keep the valves lubricated is all you need to do.
Yeah,
tops.
That's what I tell everybody.
Yeah. And I've been really happy with how our patients have done with that. Revisions are definitely a possibility. The general accepted rate is about 1% of penile implants will need some sort of intervention every year. So at about 10 years, that means about 1 out of 10 men will have needed some sort of extra work done, whether it's tweaking one of the components implants or removing and replacing the device. So premature failure can happen, but on average, these devices last about 15 years before they need to be replaced, which is, again, better than most hips, knees, or other medical devices.
Yeah. And for that too, I usually tell guys it's like wear and tear on your car, and like you're going to have to replace the brakes at some point in time. And some guys are sooner than others.
If you put a lot of miles on it, we're going to have to replace it sooner. So
Exactly.
Congratulations. That's the price you pay.
Yeah.
Yeah. Something that I think, bears mentioning is that like our patients do very well. And like, obviously we're very proud of that. But to give a little bit of perspective, there's a common statistic that's been quoted, and I don't know if it's still accurate at this point, but at one time, 75% of implants in the United States were placed by doctors that do 4 or less a year, which is a pretty scary statistic. And, in our practice, like last week, we had like a full week. Like, how many did we do in a day? I think
6.
Yeah. We'll do 6 we do like 6 or 7 in a day. And I think that conveys a huge benefit to the patient because we have that experience. Like, you've probably seen more penile implants in 2 years of working here, 2.5 years, than most physicians will in their entire careers, and 10 times over.
Yeah.
Yeah. Yeah. So I do appreciate that, that experience that comes with doing, lots of cases. So I always encourage patients, even if they reach out and they can't make it here, I'm like, find somebody who does a lot of these, ask around, look for centers of excellence, use the physician finder on the Boston Scientific or the Coloplast website, look for places that have been distinguished as doing a lot of these, because if you find a dedicated implanter, you're going to get a better outcome than, let's say, somebody who doesn't have that much experience.
Yeah. And, talking about outcomes, and we mentioned it earlier, reasonable expectations and everything too. So, but what do you typically see as like possible post-op complications?
None. No. So, the biggest concern for any surgeon is always the risk of infection. Like, that's usually top of mind. And that is why we take so many precautions. We have patients come in, 2 hours early so they can get their IV antibiotics, ahead of time. We have patients use a special wash called Hibiclens that they scrub the area for several days ahead of time. In some very certain cases, patients may even get an antibiotic, a day or two ahead of time at home. Well, it's less common. And then when we're in the operating room, we have, as you have learned, a very specific prep where we will shave patients. We will scrub them with Hibiclens, again, chlorhexidine. We then scrub them off again with isopropyl alcohol before actually using our ChloraPrep sterilization material. And so we're taking all of these steps to ensure that we are minimizing exposure as much as possible. And that's one of the things that we focus on is minimizing exposure. So that means quick surgeries that are efficient, minimizing time of the implant out of the body, minimizing extraneous movements during surgery that could introduce more bacteria into the space. And that's why, our infection rates are well under 1%. And that includes doing a lot of revision cases, a lot of men with bad diabetes and other risk factors that elevate their risk of infection compared to somebody else who may not have those issues.
Yeah. And I tell guys, this is our infection rate. Like, it's never zero. It's never going to be zero anytime you're doing, implantable devices, but you do your best to follow protocols and, keep things as low as possible for sure.
Yeah.
Bruising, swelling, all of that's common.
It's going to happen. I can't remember, the last time we had a penile implant with a hematoma that required some sort of intervention. And I think drain placement makes all the difference with that. We use that drain post-operatively so that patients don't get that swelling and don't get, that sort of pressure type pain, which can be, so uncomfortable for guys.
And the drains are super easy. They're suction bulb drains. You keep track of your output over a couple days, and then we're generally just taking them out, like I said, 2 or 3 days post-op. Sometimes we'll keep them a little bit longer if it is putting out a lot, right? Because then that's the benefit is leaving it in to get rid of that extra
guys on
fluid.
blood thinners, that sort of thing.
Yeah. But not as often that we're leaving them, longer.
So other things to keep in mind during surgery is, it's always possible to injure something in the area. So I tell patients, what's in this area: bladder, bowel, blood vessels, P-tube, nerves. We're careful to avoid all those things. It's one of the reasons why we have, other doctors and other mid-levels, PAs and nurse practitioners fly in to come train with us because we do a lot of these. So that, gives you the experience to avoid those sorts of injuries. And then the last thing, we always mention to patients is the risk of malfunction, right? Like, something could break in the device in the future procedure requiring a revision, although that rate is, considerably, is fairly low. Okay, so you've been here for 2.5 years. All right. Compare how we were doing penile implants whenever you first came here to what we're doing now as far as technique and approach goes.
Yeah, so big technique difference is, the infrapubic approach versus peniscrotal. And there's probably pros and cons to both. But as we experienced, I think infrapubic was just a lot more manual work than the peniscrotal approach.
I definitely felt like I got my cardio every single day that I was doing a day of infrapubic implants.
Yeah.
And something else is that, in order to do the infrapubic surgery well, and again, I've done over 500 infrapubic implants. I did a lot. You have to be very, very meticulous about staying extremely lateral with your cylinder placement, because you have to avoid the nerves that run at the 12 o'clock position. And whenever you're doing more complex cases, when you're doing revisions and that sort of thing, you just don't have the sort of access to the anatomy that you might otherwise. And so we ended up switching, about a year into you being here, over to a modified peniscrotal approach. And, something that I was pleasantly surprised with is that, one of the big advantages from infrapubic over peniscrotal is supposed to be operative time, which is what helps decrease infection and also postoperative pain. But I would say that our patients seem to be doing extremely well. I haven't noticed any significant increase in pain scores with this new approach. No. And I also, our data would show no increased risk of infection. And, also patients don't have to pull on their pumps anymore.
Yeah. Oh my gosh. That alone makes it worth it, I think.
Yeah. And it is nice because whenever we do have a case that is, more challenging than anticipated, maybe there's more scarring or fibrosis than, we first estimated, being in the peniscrotal aspect, approaching the penis from that, angle is just, it's so much easier and so much safer for the patient. And so I've been extremely happy with that, evolution of our practice.
Yeah. It seemed like very consistent OR surgical time and everything. And then, post-op, because I think we were concerned about having to delay activation and cycling the device and everything. But no, everyone's still at the 3 weeks like we were doing, and I think it's still working out really well.
Yeah, I've been happy with it. The only thing that I have regretted about that switch is I've had to admit to Jonathan Clavel that he was right the entire time whenever we were going and doing debates, because we used to give like little talks, and like he would talk about peniscrotal and I would talk about infrapubic, and we kind of go back and forth. And then now, like, I've been doing peniscrotal for like a year, and I'm like, oh my gosh, I don't think I'm ever going back.
You're like, who would do that?
Yeah. Oh my gosh. Right. Yeah. So with the peniscrotal approach, something else that I think is important is that this has been studied, and you actually get longer measurements going peniscrotal versus infrapubic. And I think every single patient at some point during their evaluation will make some sort of reference, or they will ask, what kind of length can they expect?
And if they don't ask, I bring it up because it's an important thing to talk about.
Yeah. So why don't you talk about that preoperative conversation, and then talk about how do we measure and assess that in the operating room?
Yeah. So in the office, I'm the one that usually brings it up, and I'm like, okay. And the next thing most guys ask about or wonder about size. Yeah. And I usually say, it's not an enhancement procedure, and you can't fit a size 13 foot in a 9 shoe. And so that's my go-to. And I use those exact numbers. No clue why.
There you go.
So
does Zach have size 13 feet?
No, I don't think so. I don't know. So whenever you're in the office, what you can do is kind of like a test is like a stretch penile length. And so you grab onto the head of the penis and you pull until you can't pull anymore. Yep. And there's your length, right?
Yeah. If I'm pulling to the point that the patient is about to fall on top of me, like, the penis isn't going to get longer than that. And we've seen that reproduce in the operating room time and time again.
Yeah. And there are a lot of things that affect size, being length and girth over time. Yeah. And I also tell them, like, what part of your body is the same as it was when you were 18? None. your penis is the same thing, you know? And so I'm sure it looks different. It obviously functions different. Length and girth change over time with just having erectile dysfunction, with decreased blood flow to that tissue. Other things can affect it. You know, diabetes, guys can get more fibrosis. If they've done injections before, if you have Peyronie's disease or scar tissue, you know, there's a lot of factors that can go into that too. And the hard part is, like, it's not like you can get into the OR and then take those things away.
Yeah.
You know, it is what it is kind of at that point.
Yeah.
And as far as like trying to oversize, like there's no benefit. It's not like you can put in an implant that's 3 times bigger than what they need and then their body will accommodate it or anything. It won't.
No, it's just excruciatingly painful, and the implant will bow and fold on itself, and it is not a good result.
Yeah, exactly. So then whenever you're in the OR and you're taking measurements, we take measurements, you know, like on the inside of the penis.
Yep.
And so you have what's called your proximal measurement and your distal measurement. So your proximal measurement on either side of the penis, you measure down to the ischial tuberosity. And so I tell guys, like, we're measuring all the way down to till we hit bone.
Yep.
Can't go further than that, right?
Well, I mean, you can.
Okay,
You're not supposed to.
Not for the purpose of
Yeah.
measurements and, you know, having the cylinders placed properly.
Yes.
And then you measure distal on either side of the corpora until you get to the end or like the tips of the corpora on either side.
Yeah.
And again, you can't go past that. If you are, you're perforating, right? It's a perforation on either side.
That's a
You
bad
don't want
day.
to do that. You have to stay in those confines. And so, you know, the big change that some guys can see is that you get corporal retraction with having erectile dysfunction over time. So those tips of the corpora on either side can pull back
Yep.
from the head of the penis. And so if the tips only go that far, then it's kind of a question of stability of the glands or the head of the penis.
Yeah. And that's something that a lot of guys have concern about. They'll ask about the glands of the penis, and they're like, oh, well, you know, with an implant, like the glands doesn't get hard. And they're technically correct, right? And whenever you inflate the implant is filling the corpora cavernosa, which are the main erectile bodies, but the glands and the tissue around the urethra are separate. That's the corpus spongiosum. But the implant doesn't compromise blood flow to that area, right? So I tell guys it's going to get as much blood flow after the surgery as it's getting before surgery. And that can be an issue for some men that have just terrible, terrible blood flow to their penis. And we do have options to help improve that blood flow with some topical medications. But for
You can
those,
still take oral medications too,
Yeah.
even with an implant in. You know, you can take Viagra or Cialis to try to improve blood flow around it. too.
yeah, when you want to swing for the fences, right? But the issue of the unstable glands. So whenever men have retraction of those erectile bodies to a point that the glands isn't stable, you know, that can be an issue for penetration sometimes. It usually gets a little bit better during the healing process when you get a little bit of scar formation at the tip. But generally speaking, if we're in the operating room and, you know, we can put our hand on top of the penis, and as we start to put pressure, it starts to deflect off to the side. That's someone that we're going to try and address with something like a glandspexy, which is a very small procedure where we make a little opening in the skin and then we throw in an anchoring stitch, sometimes just on one side, sometimes on both sides, to try and fixate that glands to the distal tip of the corpora so it's stable, and that way patients can use their implant as intended and they don't have difficulties with penetration as a result of their tissue changing due to ED.
Yeah. And I think from what I've seen, you know, glandspexys that we've done, they've worked really, really well. And it's like a noticeable difference, like very significant. The difficulty with glandspexy is just that you can have some complications associated with that too.
Yeah, which is why sometimes we don't do them at the same time as the initial implant. Sometimes we'll have to delay that because if we have a patient who has really bad vascular disease, diabetes, their risk of having a blood flow issue after surgery can be pronounced if we do that glandspexy at the same time as the implant. So it's a bit of a judgment call. Yeah.
Yeah. And then, you know, guys who do get a glandspexy, then we would delay them using their device to 6 weeks.
Yeah.
Other things that would fall into that same category would be like if they have Peyronie's disease and curvature to the extent that we have to do additional like plication sutures at the same time as the implant, same thing, that would delay to 6 weeks. So kind of just additional procedures that we're having to do at the same time, those will be delayed.
Yeah. Yeah. You know, I just when I start to think about, the technical aspects, like I'm a surgeon, I love surgery, and I love, implants. If I only had to do one surgery for the rest of my career, like this would be it. But, something that's really gratifying about this career and about this surgery really is, the patient satisfaction, like, like what that visit is like 3 months afterwards. I tell patients, that 3-month appointment, like there's something special about that whenever, the couple comes in and they're laughing and smiling and maybe flirting with each other a little bit. And that's really cool to know that you played a part in that. Yeah.
Yeah.
Although I do tell patients, I was like, remember, that's at the 3-month appointment. At the 3-week appointment, you may not like me very much, but let's say, after once you learn how to use it and you start using it, you'll start to like me a lot more. I promise.
Yeah. And, patient satisfaction is always super important. There's a lot of times in medicine where you have things that like are objectively good or objectively better. And it's just interesting how they don't always line up with patient satisfaction sometimes. But yeah, they have data for patient and partner satisfaction for the implants that are high.
Yeah, like 95, 98%. And something that was really compelling for me whenever I was going through residency training is looking at the quality of life improvement of cancer patients who had a prostate cancer diagnosis. And then what did that feel like whenever they got that first PSA test afterwards that told them they were cancer free? Like, what did that weight coming off feel like? What was that improvement in their quality of life? And then they looked at patients who had erectile dysfunction who were undergoing penile implant placement, and they rated that improvement in quality of life as the same as whenever they had previously gotten a cancer-free result. And so that's really, really cool that, what we're doing on a day-to-day basis, at least from a quality of life standpoint, is on par with curing cancer. My friend Chad Reichard is gonna take umbrage with that.
Yeah, I'm gonna let him know you said that.
That's totally fine. It's the data. You can't argue with the data. Yeah.
No, I mean it's an important thing if you feel that it's an important thing, and I kind of have that conversation with guys too. That it's like you're not broken if you also don't want this. Because I have some people who are like, well, maybe that's not important to me. Maybe I am not interested in having penetrative sex anymore or something. Because like again,
let us check your testosterone.
Sure. But no, I mean, things are complicated, right? And we do see patients who have gone through cancer treatment or something, like they've been through a lot. And, so it's sometimes I just see guys and I say, like, if your end goal is to be able to get an erection that is sufficient for penetration, we can get you there.
Yep.
If that's not your end goal, also okay.
Yeah. And I think that it's important for patients to know that, wanting to feel whole again is okay. Like there are a lot of men that want a penile implant, not necessarily because they have plans for, a wild and crazy, lifestyle where they're having, sex every day or, several times a week, but they just want to know that they can. They want to feel whole again. I often joke, it's kind of like why my truck has 4-wheel drive. Not that I would take it off road, but I know that I can. And that's what's really important after all. So, wanting to feel whole, wanting to feel complete, like having that desire, you're also not broken.
Oh,
right?
sure.
Like,
yeah.
That's totally valid. And if that's where you're coming from, then you deserve treatment. Yeah. Yeah. So in the end, penile implants are safe, effective, spontaneous, and hidden. So if you're looking at all of your different treatment options, it's the only one that checks all 4 of those boxes and doesn't require you to keep coming back to the doctor, which is why I think we've dedicated our practice to that as men's health experts.
Yeah. So it's a good option. If this is something that you're interested in, definitely look at, making an appointment with someone who specializes in men's health and see if it's a good option for you.
Absolutely. Well, again, thanks for staying after clinic.
All right. See you next time.
See you.